climate change and oil vulnerability. We have some excellent speakers here today. Each will give a presentation and you will be able to ask questions following the on-screen instructions. For typing your comments, use the box at the bottom.
Oops.
If you have any difficulties, please contact Sito Maramba and the details given on the slide. You can either email him or call him on the number. The four speakers are Robin Stott, Linley Owen, Andy Nichols and Rob Hopkins, and each will have a chat room of their own. You are currently logged on to the main chat room, and each speaker has a chat room. The next slide will give you details of which chat room to log into for each of the speakers. To change from one chat room to the next, simply type in the number of the chat room and that will log you on.
So I need to type
In /room space R1. You can ask a question or make a comment at any time during the presentation. If you're responding to someone else's comment, please remember to preface it so that others know who it is aimed at or who you're replying to. So, for example, type in, "Paul, can you tell me?" or "Janet, I disagree with what you say." I'd now like to introduce to you Dr. Robin Stott. Robin is a former consultant general physician and hospital medical director who is currently chairman of the UK Medical Peace and Environment Group and co-chair of the Climate and Health Council. Robin will talk about some of the consequences of global warming and their impact on health. Welcome, Robin.
Thank you very much, Janet. It's great to be here. Over the next 15 minutes or so, I'm going to, predominantly from a health perspective, talk about some of the problems which are going to confront us in this new era of climate change. The talk outline is as depicted here, and I'll go through each of these in turn. But first, why is climate change such a problem for health? To answer that question, I really need to talk about what actually constitutes good health and the structures and frameworks which will facilitate the emergence of good health in our societies. And they're very well known and in some respects simple to outline in a clear way. What we need if we want a health-creating civilization, which of course is the objective and aim, I think, of all of us who are interested in global health and health for people at large, is first that all people have reasonable access to economic and social resources. There are many of these, and we may come back later to defining that more clearly, but in essence a good marker is that money, which is a reasonable marker of the composite of economic and social resource, is reasonably clearly and equally distributed through the society. The second is that Earth's gifts are shared amongst humans fairly without compromising future generations and other than humans. This, of course, implies that we live within our environmental limits. So, what we need for a health-creating civilization is that the social, environmental and economic determinants of health, which are, as I've said, that we have a fair share of resources and we live within environmental limits, are woven into a tapestry supporting a fair shares and so healthy world. I don't need to tell you that that's not the present case. And there are two great problems which are undermining this wonderful concept we have, this wonderful idea which needs to be turned into a reality of a health-creating civilization. They are global climate change and the everywhere prevalent gap in resources between the materially rich and the materially poor. Why are these causing such a problem? Well, first let's take a look at global warming, which is a shorthand for global climate change. The predicted rise in temperature by 2100, which is around 2 to 3.5 degrees, will cause a number of problems which will impact seriously on health. Disruption of agriculture through changing rain patterns and soil use will obviously have a major implication for those that already don't get enough to eat, and starvation is a major anxiety. The rising sea levels will displace many people by 2100. The extent to which the sea level rise is going to be, of course, much debated, but most of the great metropolises of the world are close to the sea, and significant sea level rise will displace many more, in fact, than 120 million people. That's the minimal that we consider may be displaced by this particular problem. There are, of course, climatic conditions which favour things like mosquitoes and other beasts and insects which transmit disease, and the likelihood is that their area of activity will extend significantly, and the prediction is that, for instance, there may be another 60 million extra malaria cases a year. And then, of course, there's a problem of extreme weather, heat waves, hurricanes, flooding, and we all know even now of the damage this causes to people's livelihoods and therefore their health. But most important is that this will actually cause enormous social and economic dislocation. And we know from the unfortunate history of the last 50, 60 and 100 years that this gives rise to substantial health problems, with a major increase in death, particularly of women and children. And of course the other thing which is really important to recognise is that the global warming and climate change, the impact of this, although it's going to be on all of us, is going to be greatest on the income-poor world, and so it will increase the resource gap to which I alluded earlier on. And just to highlight what that resource gap is, it's worth looking at one or two figures. 11 people own more than the total GDP of the 49 least developed countries. If you look at global trade, $10 million a minute, the 49 poorest countries have 0.4% of it. If you look at high-income countries, 20% of the world's population consume 86% of the goods. 40% of the world's population in 64 countries have an income of less than $2 per day. And 2.4 billion people lack access to sanitation, and 1.1 billion have no water in their homes. Infant mortality rate, which is what IMR means, is a measure of deaths per 1,000 live births. In Angola it's 250, in UK it's 7. Life expectancy, Angola 40, UK 78. Maternal mortality per 100,000 births, Angola 600, UK 7. I think we need say no more about how disparity has such a terrifying impact on health. Just looking at health professions for a minute, and although what I'm going to say predominantly concerns health professionals, it is actually germane and pertinent to all people. We have two professional obligations. The first is as written here, which is to care for individual patients in a humane, compassionate and scientifically effective way. The second, which is the one that I'm going to talk about dominantly, and which really is the one that's important for us here, is to ensure that the society we live in is health creating so that all global inhabitants can enjoy good health. So we know that at the moment that is not the situation. We know what the problems are. We know that climate change amplifies them. What do we need to do? I suggest there are 5 things we need to do, and I've listed them here, and I'll go through them briefly in the next few minutes. We need to inform. We need to inform the health consequences, as I've just done. We need to recognise that policies for mitigation and policies for adaptation are available, and we need to promote them. And we need to be very clear about the benefits to health of so doing. There are substantial benefits to all our healths if we reverse the resource gap and tackle climate change. We need, secondly, to affirm. By that I mean we need to measure and reduce our own personal CO2 emissions and ensure that the organisations we are associated with do likewise. Informing and affirming, what I call putting our own house in order, won't solve the problem, but gives us the moral right to advocate for global solutions which will. And when in place, these global solutions will accelerate our own local initiatives. So I'm going to talk now about advocacy, which is really, as I said, stressing the need for a global framework which must simultaneously tackle climate change and the resource gap. Only in this way can it be health promoting. It's what we call a fair share solution, a fair share of the residual carbon we can emit, consistent with us trying to keep within a 450 parts per million CO2 in the atmosphere target. The reason for that target is it's a likely tipping point for even more serious climate change problems than those we presently face. And of course we need a fair share of the resources which come from the use of this carbon. The most feasible present fair shares option is contraction and convergence, and I'll take a few minutes to explain what this is. Contraction says that we have to globally agree a carbon budget to keep atmospheric CO2 levels below 450 parts per million. That's just a scientific calculation which is relatively easy to do. We reduce this over where we allocate this budget over an agreed but negotiable timescale, probably 50 years, until the amount emitted equals the amount the world can cope with. It's a variable amount that it's not absolutely certain, but it's around 8 billion tonnes of carbon dioxide per year, which is 1.4 tonnes per person per year, roughly. Of course, this amount that we can allow to emit depends on protecting carbon sinks, and that's an absolute minority. But by contracting the amount of carbon we emit, this process will stabilise atmospheric CO2 levels and therefore achieve one of the goals we set ourselves for getting to a health-promoting civilization. Convergence is the second part of this framework, and what it implies is moving rapidly to an equal entitlement of the carbon budget to each person in the world. So it's a convergence to an equal share of Earth's bounties and support systems, a just and ethical proposition. The frugal emitters, usually the poor, will be able to use their unused entitlements to the profligate emitters, the rich, those of us living mainly in the rich north. And of course, for compelling financial reasons, the profligate emitters will wish to reduce the amount of carbon they use, and the frugal emitters will wish to keep as much carbon as possible so they can sell it and generate money, and all will invest in low carbon initiatives. Given that each tonne of carbon entitlement will have a substantial financial value, this process will enable a framework-based market to transfer of money to the poor to flourish. This would more than cover the $120 per person which Jonathan Sachs of the UN Millennium Project has estimated will be required to deliver the Millennium Goals in Africa. That's $120 per person per year. And of course this resource would be a flowing resource for a considerable period of time. So contraction and convergence creates a policy virtuous cycle at a global level, enabling economic and social progress within environmental limits. It unleashes a worldwide boom in low-carbon entrepreneurial activity, and it facilitates the development and implementation of virtuous cycles for coping with the problems of waste, excessive fossil fuel use, biodiversity loss, noise at national, regional, community and personal levels. Implementing virtuous cycles is essential for promoting sustainability and well-being, and of course will be driven by this global framework that I've just talked about. So what do we need further to do apart from the informing, affirming and advocating? We need to innovate, seeking new institutional forms for delivering the C&C framework. There are many new networks which have been facilitated by the technology such as that we're using now, and we need to work with those and see how we can develop them to implement the CNC framework. And we need to disseminate the information, recruiting as many partners as possible to the cause. As far as health professionals are concerned, the Climate and Health Council, the website of which is there, is an organisation which is trying to do this, and we encourage you to join and support it. And to get further information about contraction and convergence, you can go onto the other website, which is also identified there. Many of the practical consequences of what I've been suggesting will be discussed in the next session when we talk about what is actually happening in southwest of the United Kingdom. Thank you very much.
If you'd like to ask questions for Robin Stott, type /room space R1, and that will take you to his room where you can put questions or comments while the other presentations continue. Now I'd like to introduce our next speaker, who is Linley Owen. Linley is a consultant in public health for Cornwall and the Isles of Scilly PCT. Linley will use examples from Cornwall to highlight the actions that can be taken by health professionals to mitigate and adapt to climate change and energy vulnerability. Welcome to Linley.
Right, thank you very much indeed, and it's great to be here, and particularly following Robin. And I'm going to talk about action on climate change and some work in progress that's going on in Cornwall. But I'd like to start with a quote from Richard Horton. He's the editor of The Lancet, and he spoke at the Climate Change and Health Conference at the Royal College of Physicians event. I'll put that website on the chat room after this speech because it's all still there now, it's all relevant, and anyone can download any of those presentations. If you haven't already done so, I commend them to you. And Richard Horton issued a clear challenge, which is up here on the screen for you. If the medical profession, and for that I read health workers in total, are silent on the issue of energy shortage and inequity, then it's little short of criminal. Now, this information comes from a very recent document from the United States Public Health Association, because they've got climate change and global warming is an issue for them in their Public Health Week that's coming up in March this year. And so they say that there's this challenge of keeping people healthy and addressing the impact of climate change, and there's enormous co-benefits. That's a term I've heard used by Ian Roberts, the Professor of Public Health at the London School of Hygiene and Tropical Medicine. I think that's really important to keep in our minds, because choices that health professionals, particularly public health professionals, have been urging on people for decades, if not centuries, are just the sort of things that will help deal with the effects of climate change. And the American Public Health Association asks these three questions that everyone, not just health professionals, but particularly on health professionals. What strategies are being spearheaded to address this, which is the biggest threat of all? It dwarfs all other threats. So what strategies are being implemented, are being considered at this stage? And then as individuals, what action are we all taking to reduce our contribution to climate change and help our families? Incidentally, Robin mentioned to me before this talk that on the WHO website there are brilliant, succinct fact sheets aimed at different groups. There's a good one on young people, there's one for health professionals, there's one for the general public, and again in the chat room I'll put the web link. And what measures are already being implemented elsewhere to protect children and elderly? How do we bring them to our community? How do we learn from other places? And this wheel shows from the American publication Center for Disease Control, shows the cycle from evaluation through assessment around policy development into assurance. And this cycle of managing the system, and it all coming from good research in the middle. And without good research we would not know the problem that we're facing now. And it's the bottom right hand part of this cycle that's particularly important for today's talk, and that's around informing, educating and mobilising community partnerships. So there's a great opportunity here for the public health community to work even more closely with partners. A lot of this work's going on now. It's simply a matter of scaling it up and making it more intensive. And in Cornwall there's this organisation quite new called Groundswell, and I want to tell you a bit more about Groundswell. It's a whole collection of people from all walks of life, all ages and all parts of the county. Some are representative of the community, a few are politicians, but most are ordinary people working in different ways, but they have one thing in common. They think there's a challenge that has to be faced, and the best way to face it is working locally in partnership. We have people from the environment sector, we have academics, we have people from farming, of course, and tourism, a very important part of Cornwall's economy. We have health people there, we have people from the building sector, energy, voluntary sector, transport, politicians and the arts. And Groundswell has agreed a vision. And here it is, and I'll let you read it. Note that readiness to adapt rapidly to change. We've learnt in recent years and months that the climate change challenge is urgent. We have to act now. We used to think it was a medium-term issue. We used to think there's some debate about it. Now we know different. We think there's still time, you'll hear more of that from Rob Hopkins later on, for us to work out ways of dealing with climate change which actually enhance life. A lot of people seem to think it all involves sacrifice. I don't believe that. And the Groundswell is an exciting, positive organisation. And it has a mission, and here it is, to alert the people of Cornwall at all levels to the realities of this century, the 21st century. Climate change, declining oil supplies and other resources, and the dramatic opportunity for personal, family and community action resulting from them. To create and nurture the environment for rapid and dramatic change, and describe and guide that change in a way that protects our vision. I'll put the Groundswell link on the chat room. And to cultivate and develop collaborative actions to address social and economic challenges. Groundswell has already, in its short existence of little over a year, produced two major reports. One calling into question the economic case for the expansion of Newquay Airport, and the other on the impact of peak oil on rural communities. And both these reports can be read via the Groundswell website. And we hope shortly to be preparing a new report on agriculture and climate change. And we'll be giving opportunity to people to take part in the creation of that new report. Now in Cornwall, transition, you'll hear much more of that from Rob, is already happening in these areas. And if you live in Cornwall, if this is one of your hometowns and you've not made contact with the transition group, I urge you to do so. If you don't see a town listed there, that doesn't mean to say there aren't people in your locality who are concerned about climate change and peak oil and would be interested in setting up a transition group. So find out through Groundswell who else might be interested. Now the health co-benefits are really where the NHS should step up to the plate and take a leadership role in making sure that people move from contemplating change to actually taking action. If the transition model of more local solutions, local sourcing of your foods and needs, instead when you need something buying new, look around, join your local free cycle group, see if you can obtain it from someone else who no longer has a use for it, see if you can pass on materials that you have. I'll put the free cycle website on the chat room as well. Cut your motor transport, cut your travel altogether. If you feel you need to travel somewhere, think, are there other ways of doing it? Share. Reduce your meat consumption. I'm not saying everybody's got to be a vegan, but what Ian Roberts said quite clearly was that if on the whole, the population of the world cut its average protein consumption to about 90 grams a day, we would all benefit from better health. A lot of the Western-type diseases arise from excessive meat consumption. Buying food locally means it's less likely to need preserving, it's certainly involved fewer food miles, and it stimulates the local economy. And when transport costs rise, they will rise, local food will become cheaper. But if you've not been stimulating the market in the meantime, it won't be there for you to use. Better mental health. The transition approach is very life-affirming. It involves groups getting together and seeking common solutions, and seeing that there is a way that local communities can solve their problems is very beneficial to mental health. And anxiety and depression is among the biggest scourges of health, not just in Britain but worldwide. Active travel, by this I mean, and people who know me will say, oh, he's going to bang on about bicycles, but actually walking is what matters most. Most people can do it, most people don't do enough, and it is the best buy in keeping yourself healthy. Clean air. Because pollution is invisible, we often don't realise the extent to which our air is polluted. But just imagine if car makers were required, instead of to put an exhaust at the back and the outside of the vehicle, to put the exhaust inside. Would you buy such a vehicle? Well, think about it. If you wouldn't, why are you happy driving and putting that air out into the atmosphere of every community you drive through, past every school you drive past? Better cardiovascular fitness would definitely be a benefit from more active travel and reduced motor travel. Better social networks, I've referred to those earlier. Skilling and reskilling, you'll hear more about that from Rob, so I won't go into that in detail at this stage, but if you want to chat I can give examples there. And reduced obesity. The Foresight report last year and the government's obesity strategy show quite clearly that a lot of what needs to be done to reduce the incredibly rapidly rising levels of obesity are nothing to do with medicine or surgery. They're to do with our everyday lives and making sure we get regular physical activity every day and we eat healthily and sufficiently and not excessively. And reduce cancer rates, again linked to reducing meat consumption and reduced obesity. And lower noise pollution linked with clean air and better, more active travel. And these are the links between those groups. Look at them. It's a complex web. You'll hear more from Rob about webs. Coming to Cornwall specifically, the Cornwall Food Programme is becoming rapidly very famous throughout the country and beyond. And quite rightly so, because it's putting into a strategic and scaling up this attitude of let's source as much as we can locally. It cuts food miles, and it's going to improve diet for the hospitals and other institutions across Cornwall. It won't stop at the door of the NHS. A lot of their customers will come from other organisations in the county, and it will be a terrific boost to local agriculture, so other consumers will benefit as well. The carbon strategy, which last week was approved by the Healthy Futures Board, will shortly be going to each of the NHS Trust boards, and we're working closely with the proposed One Cornwall local authority on making sure that our carbon strategies integrate, work together, not against each other. And a lot of that work's been done by Mark Summers, who leads for energy for the NHS. And we've been visited by leaders from the NHS New Sustainability Unit, and one of the things they're particularly interested in is the carbon strategy and also the food programme. And the Mobilise project is about active travel. A lot of people in Cornwall are aware of Paddle Back the Years for regular cycle rides for people who are not that fit and who are sort of getting back into it. And now Stroll Back the Years is becoming a rapidly rising series of local walking groups. And a lot of this is funded through Sustrans, the big lottery fund, and is funded for the next 4 years. And so in most areas of Cornwall there's a stroll back walk or a pedal back ride very close to where people live. And health trainers have a really important role here, because although they're a relatively new small workforce now, they're reaching out into areas of the community where the health service has not always managed to reach people effectively. And it's helping people in very practical ways. about making their lifestyle better, and at the same time it relates to this topic of climate change. Okay, thank you very much. I'm now going to the chat room, so if you've got any questions I'd be happy to answer them and hand over. Thank you.
If you'd like to send in questions or comments to Linley, please type in /room space R2 and add your comments. Now I would like to introduce Andy Nichols, who is a lecturer in the Faculty of Health and Social Work at the University of Plymouth here, and he continues to work with the Health Protection Agency. Andy will talk specifically about the effects of climate change on in coastal and rural communities. Welcome, Andy.
Okay. Good afternoon. We've heard about the international and the kind of national impact of climate change and sustainability. My intention is to talk about something on a very local level, and the aim of this talk really is to discuss two incidents highlighting the impact of climate change, or the potential impact of climate change, on infectious disease management. There's plenty of evidence to suggest that climate change and other environmental disturbances are important in the transmission of zoonotic infections. Zoonotic infections being infections transmitted by birds, insects, animals in general. For example, malaria often is seen in stories in the popular press, suggestions that it may become endemic in the UK again. I think that's fairly unlikely. But climate change could facilitate some change in the transmission of malaria in the UK, and we may start to see localised outbreaks in the future. It's not that long ago that we actually did have malaria in the UK. I think the last indigenous case was in 1953 or something along those lines, so not that long ago. And the similar outlook for other organisms that are transmitted by mosquitoes or birds, for instance West Nile virus. There are various causes suggested for the changing populations and the distribution of mosquitoes and their activity. I was listening to someone talking the other day about the international trade in used tyres, which apparently have contributed to mosquitoes moving around the world. I wasn't aware of that as a vector of mosquito movement, but apparently there is this trade in used tyres that is quite significant in moving mosquitoes around the world. In the UK, I wouldn't claim to be an entomologist, but I do know that in the UK we have about 30 species of mosquitoes presently in the UK, and some of these species are quite capable of transmitting infection. They are present in the UK. However, they are unlikely to be in sufficient numbers to pose a sustained threat of transmission to humans. But that doesn't mean to say that there wouldn't still be cause for concern if there was a changing pattern in mosquito distribution and mosquito population. And this is an example here of our Cornish mosquitoes. There was a plague in a small Cornish coastal town. There was reports of a mosquito plague. And I've got here some quotes from local newspapers which just give a flavour of the kind of upset and concern that was experienced locally. So you can see immediately that people were starting to think that because these mosquitoes were there was the risk of malaria. People were writing into local newspapers complaining about the environment, saying that environmental management could have been improved. And certainly in this instance, there were reports that at least 4 people were hospitalised, admitted to hospital, but there was no evidence to suggest really that any of these admissions were linked to the plague of mosquitoes that were being dealt with at the time. That didn't mean to say that the local people were still any less concerned, and there were numbers of people there that were fairly convinced that these mosquitoes were posing a health risk to the local population. As a result of this, some investigation was carried out. This was carried out by a combination of the Environment Agency, local environmental health officers and the Health Protection Agency. On investigation, it was found that the plague of mosquitoes was likely to be caused by a species of mosquito called Aedes detritus, which I think is also known as a salt marsh mosquito. The health risks associated with this particular breed of mosquito are thought to be relatively low. However, in this instance, public concerns may continue to be raised, and it's difficult to predict whether or not there will be a similar plague of mosquitoes this summer, as this particular species is a problem between March and September. So we'll have to wait and see whether or not we have a similar situation this coming year. So in this particular instance, although there was an awful lot of public concern relating to this mosquito plague, and we're all aware of the potential health risks associated with mosquitoes, in this particular instance the actual healthcare problems appear to be fairly small. But that doesn't mean to say that that situation might not change in the future, and we'll need to be aware of it. This is just a slide here, is just a close-up of an Aedes mosquito. I think that's a tiger mosquito. We don't actually get that one in the UK, but it's a nice big mosquito, so I thought it would make a good picture. Having said that we didn't really have much of a problem associated with the mosquitoes, next outbreak we certainly did have some healthcare problems, and this is more to do with flooding, rainfall and unusual rainfall events that may be associated with climate change and global warming. This is the village of Boscastle in North Cornwall, and this was following an extremely unusual rainfall event. As you can see, that flooding is not the kind of thing that would normally be experienced in Boscastle in a normal summer. And around about the time of this unusual rainfall event, we also had in Cornwall an outbreak of E. coli 0157 infection in amongst a group of children. So it was around about the same kind of time, so you can imagine the torrential rainfall that we had around about this time. There is evidence to suggest that these kind of extreme rainfall events will lead to increased surface water acquiring pathogens, bacteria, and then those pathogens being transmitted then into streams and into other surface waters. In the case of the Cornish outbreak, this was in August of 2004, and there were these 7 children all on holiday in Cornwall, and although they were all staying at different sites within the county, they had all been to one particular area. On investigation, it was found that the isolates from these 7 cases, the organism that was isolated from these 7 cases, was able to be typed as an E. coli 0157, and we could also find out what the actual phage type was, which indicates that all of these cases acquired their infection from the same place, and quite likely they managed to pick it up at around about the same time as well, which kind of supports the evidence there. All had visited the same seaside beach and the stream flowing across it. And this is a slide here. You can see this is a typical Cornish beach with a nice stream running across it in the middle there. And when we're looking at these 7 cases that we've got, they were all in fairly smallish children. So from a point of view of a parent, I suppose it's quite desirable that the kids would be playing in the shallower, safer waters in the stream or around the stream, rather than out to sea in amongst the breakers where it might have been slightly less safe. So that gives you an idea of the kind of environment where we were having the outbreak. Again, investigation of the stream and of the surrounding area, we found that there were increased coliforms were found in the stream. Coliforms being organisms that have emerged from a digestive tract somewhere. And to add to the suspicion cattle were found to be grazing upstream. So the suggestion here was that the source of the outbreak of the E. coli 157 infections in these kids was caused by the contaminated stream flowing across the beach. That was the suggestion. We saw the heavy rainfall in Boscastle in the previous slide. That kind of absolute deluge, that kind of unusual rainfall event may well have preceded the outbreak and would have caused large amounts of water leading off the fields into the streams and then off into the sea. If we follow the chain of, we could look at, we have cattle feces in the fields. The fields are contaminated with the cattle feces that contain E. coli 157. Heavy rainfall, an absolute downpour of rain on the field, which causes a very rapid, large-scale water drain off from the fields, which then run into the streams. The streams then run down onto the water courses and onto the beaches and into the bathing waters, where, in this case, the children were playing. So the suggestion is then, it was fairly conclusive that the evidence was fairly conclusive to suggest that that was the route of infection in this E. coli 157 outbreak. And the suggestion is that extreme rainfall events, which lead to this increased rainfall over short periods, could and will lead to increased bacteria in surface water. We're going to say that this heavy rainfall provides a bolus, a pulse of contamination, if you like, which runs suddenly into water courses and into bathing areas and produces a very high level of bacterial contamination within the bathing areas. So what can we do about that? I think really we have to be looking at planning and preparation. Can we predict what an extreme rainfall event might be, and how extreme does this rainfall event have to become before we start to see this bolus of contamination into the water courses and into bathing areas? If we can predict them, then can we prepare for them, and can we work to try and prevent similar kind of outbreaks occurring in the future? I've just got some references here, a fairly general one on the health effects of climate change in the UK, and also another one here more specific to the actual outbreak of E. coli 157 that I was talking about in the presentation. Thank you very much.
If you'd like to send in your questions or comments for Andy, please type in /room space 3 R3 and Andy will take your questions and your comments. I'd now like to hand over to our final speaker of the day, who is Rob Hopkins. Rob is founder of the Transition Town Totnes Initiative and director of the Transition Network. Rob is going to talk about the impact of peak oil on healthcare and will emphasise the importance of developing sustainable and resilient communities. So welcome to Rob.
We on?
Yeah.
Okay. Good afternoon. Well, isn't this fantastic? We never ever need to fly again. I think this is all wonderful. Well, I'm going to weave in some extra bits onto what people have already said. Robin talked very well about the potential horrors of climate change, and my starting point is from the idea that we can actually still avert this, and that the worst horrors of what he talked about are still avoidable. And also I want to build on what Lindley started talking about in terms of the role of the local and what we can actually do in a positive kind of a framework. So we can look really at the period of the last 150 years as being the petroleum interval, as a time where we've drawn all this material out of the ground. It's the incredibly abundant resource material that is fossil fuel, and we now use about 1 million years worth of ancient sunlight a year in order to support our civilization. So we use it for building, for transport, for agriculture, for plastics, all sorts of things, and for medicine. And our medical system has come to be as underpinned by this extraordinary material as any other aspect of our lives in terms of energy intensive procedures, drugs, materials, and so on. And the idea of peak oil is relatively straightforward. It's the idea there is a finite amount of oil laid down in the world, that we use it at a certain but basically, when you look at the lifespan of a particular oil field, about halfway through, that production starts to go into decline, and once you hit that point, the production is downhill all the way from there. So what matters when people say, do you mean we're running out of oil? What really matters is the point when you get about halfway through, which is when you begin to run out of cheap oil. Where we find ourselves now. We're running out of easy to get at, cheap, accessible oil, and what we're increasingly moving into is the harder to get at stuff. And when we do that, during the oil age, we've started out using the biggest oil fields first. You know, it's human nature. The easiest, the biggest, we start on those first, and then we get through the smaller and smaller ones. So the big oil fields that were discovered in the 30s and 40s, which we really relied on for all of our oil production, are getting very old, very tired at this stage, and increasingly we're looking at smaller and smaller and smaller oil fields to fill the gap. And this is an example of that. This is the North Sea. So you can see the biggest ones first, and now as they're getting more and more tired, we're looking for smaller and smaller and smaller fields to fill the gap, and they just cannot do that. So sometimes people talk about the peak oil theory as if it's some theoretical thing. There are 98 oil producing nations in the world, of whom already about over 60 have already passed this peak. The US did it in 1970, the UK did it a few years ago. And once you go past that peak, no amount of new technology is so on. It's an irrevocable change in direction. So we're looking at when that will happen for the entire world. So discovery peaked in 1965, has been in decline ever since. People argue there must be enormous reserves still out there to be found. They fit within a particular pattern which has been evolving and continues to be the case. And 1981 was the first year we started to use more oil than we were finding. So we now use 4 or 5 barrels of oil for every one new one that we find. And when might this peak be? There are a range of arguments, but I think the most reliable are coming in now as it having either already happened or sometime between 2010 and 2012, something like that, so it's not too far away. And where we find ourselves now is that we're bumping along the top of a plateau. We've now got to $110 a barrel, and that's still failing to increase production. So we're bumping along a plateau in that context. And what we're increasingly falling back on is the unconventional oils, the things like the Alberta tar sands, the deep water oil, stuff that 10 years ago we wouldn't have even bothered to go looking for. There is lots of oil still out there, but as I said, it's not cheap, it's hard to get at, and the carbon implications of it get worse and worse the more we go into that stuff. And increasingly we fall back onto biofuels, a huge growing industry, which from many perspectives is somewhere we really don't want to go. And we could spend quite a while, I imagine, looking at the health implications of biofuels in terms of the starvation side effects of this rapid increase. So in the UK we find ourselves in a position where all of our indigenous energy sources are declining, and this is really the context when we're looking at the UK and at how health and medicine is going to develop and transition over the next 15-20 years. This is the context in which we need to look at it. So a plan A for medicine, which is what's happening now, is the idea that every year we're going to have more and more cheap energy at our disposal in order to make it all happen. The reality is that actually that energy is declining and the price of it is increasing, and we need a plan B which looks at what our medical system might look like in this new context. So just to sum up that peak oil thing, because it might be new to some of you there. The blue there is discovery, peaked in 1965, declining ever since. Production is in green, plateauing sometime around now, and then red is what demand wants to do, but it can't do that because there isn't enough demand, there isn't enough raw material, and secondly because the climate implications are terrifying. So I like to look at it like this, and I hope you find this a useful way of looking at where we find ourselves now. This is a very simple graph. You've got rapid depletion and slow depletion on the horizontal and proactive and reactive on the vertical. So if we have a slow depletion do anything, then we have a sort of climate chaos, horrible meltdown scenarios that are so Robin talked about so eloquently. If we have very rapid depletion and we don't do anything, then we have a sort of collapse scenario, which is something obviously we would really rather avoid. If we have very slow depletion and we really engage, then we can do this sort of high-tech sustainable development model. I argue that actually, given the rapid onset of depletion, what we're looking at is a lean economy, a power down, a moving more towards building the local economy in a low energy context. And if there's one thing you take away from today, I think this is very important, which is that we need to look at peak oil and climate change as two aspects of the same challenge. If we look at peak oil on its own, like the Hirsch report did in 2005, we're just looking at getting more liquid fuels out of something else. If we look at climate change on its own, like the Stern report did, we're just looking at techno-fix solutions to climate change. But I argue that we need to look at those two and overlap them. And when we do that, cutting carbon with an unprecedented urgency is paramount, but equally paramount is the building of resilience on a local level. That's the ability of our communities and systems to withstand shock from the outside. So one example of resilience, this is Totnes 1930s, all the businesses owned by local people, whole areas of the town dedicated to food production, all of that has been since dismantled. This was a man who grew food within the town. And I would argue that systems like this, that we now look at as being behind the times, were actually way ahead of their times, and that maybe in 15 years or so what we're looking at is not just food production back in urban areas, but is actually the production of medicinal plants, local medicines and materials like that. And we've seen the same thing in Cuba, where they've had to make this transition towards building local resilience in a productive kind of a sense. And David Fleming, the economist, says that localization stands at best at the limits of practical possibility, but it has a decisive argument in its favour that there will be no alternative. So once we start to look at taking out liquid fuels out and really addressing the scale of the challenge that climate change presents, as Robin laid out, then one of the things that's going to be really key to that is building local resilience and strengthening the local economy. So the transition model, which Lindy talked about, is the idea of a process which acts as a catalyst at a local level to explore how that can happen, how that resilience can start to be put in place. The first one in the UK was in Totnes. There are now over 45, two in New Zealand, one in Australia, the rest all around the UK, from cities down to villages. It's one of the most quickly growing movements in the world, as far as I'm aware. So we've been here before in many ways. In 1973 and 1979, the oil crises, empty motorways, ran out of petrol, Jimmy Carter putting solar panels on the roof of the White House. Did that cause a great collapse in what we were doing? What it actually did was it triggered the most incredible upswelling in creativity and imagination. The first solar houses built, the first solar panels, the first wind, earth-sheltered buildings. There was a period then where there was amazing upswelling of creativity, which then when we got to 1980, like Sleeping Beauty, we all got pricked with a thorn and all went back to sleep for 25 years. And there was creativity as well within the health sector, and a lot of people asking questions about what the health sector might look like beyond oil that was explored then, and then kind of went back to sleep again. And I want to just read. How are we doing for time? Are we okay? Okay. I wanted to just read a little bit here, because one of the things that's very important with the transition model is this idea of visioning and starting out with a vision of how the world beyond oil can be. So this is something that I wrote recently in the Transition Handbook that we just published, which is about health, and it's a view from 2030, looking back to now. Today, our idea of health, how to create it and maintain it, has changed markedly from that of 20 years ago. The health service had to rethink itself as the oil price made many of its practices and approaches unaffordable, and it faced the very real threat of collapsing completely. The closure of local hospitals in favour of centralised ones, so rampant 20 years ago, has been reversed, and local healthcare centres are now not just about treating illness, but promoting health in many diverse ways. They have forged partnerships with local schools, promoting food growing and familiarising young people with the whole cycle from seed to salad. The well-being of individual is seen as inseparable from the health of the community. Human biology is now a compulsory school subject and has expanded to include nutrition and basic herbalism. About half of the medicines prescribed by doctors are now locally sourced, with local farmers growing certain key medicinal plants which are processed in local laboratories. Local chemists now make over 50% of the medicines they sell on the premises. Doctors are able to prescribe a range of complementary treatments, as well as involvement in local community gardens and access to affordable good food. The growth in access to meaningful work, the rebuilding of social cohesion, and an emerging common sense of purpose has resulted in fewer stress-related illnesses and cases of depression. Conventional and complementary practitioners are seen very much as two sides of the same coin, and the concept of promoting health rather than just treating disease has led to a range of innovative measures. So just to conclude, I think that actually inherent within the challenges of peak oil and climate change is the potential to do something really extraordinary. There's a huge opportunity there. And so I like to look at it like this. This is Hubbert's famous peak oil bell curve. And we've been led really over a long time to look at this in this way of being like a mountain that we've spent the last 150 years bravely climbing up of, and now we stand there we can see further than any generations ever have before. We have amazing opportunities and so on, but actually now we need to come down the other end, and it's like trying to draw a reluctant child home from a birthday party. And I was talking a while ago to David Wasdell, the climate scientist, and he suggested what would it look like actually if we flipped that upside down, and we saw the oil age rather as a deep lagoon, fetid lagoon that we've dived into because someone told us there was enormous wealth lying at the bottom. And the deeper we've dived, the more our internal systems have been telling us this really isn't very good for us. And now we're right down at the bottom, rooting around in the sticky tar, and the pressure is intense. And so then when we look up, we can still see the light shining down through the liquid above us. So looked at that way, actually our rush towards a zero carbon positive, zero fossil fuel world, rather than being dragged away from something we're inherently attached to, actually becomes a collective rush towards self-preservation and to being able to feel the sunlight on our skin again and feel the fresh air. So I think that actually, although the challenges presented by peak oil and climate change for the medical system are enormous, actually if we can embrace and engage with this with creativity, imagination and adaptability, the same creativity and imagination that created such an amazing system in the first place, that we can actually redesign it for this transition to the benefit of everybody. Thank you very much for your time today.
If you'd like to send in questions or comments for Rob Hopkins, please type in /room space R4. So that is /room space R4, and that will take you to his chat room where you can ask him questions and send in comments. All our speakers are available until 3:30 to answer questions, and that's when the session ends. So I'd like to take this opportunity to thank our speakers, and also to thank RayJones, our Professor of Health Informatics, for his wonderful, slick operation of all this fabulous technical equipment. If you would like further information about further events such as this, you can email Ray at ray.jones@plymouth.ac.uk, and we would also like some feedback on this event, so I would encourage you to email your feedback to Ray. So thank you very much for participating.
In resources between the materially rich and the materially poor. Why are these causing such a problem? Well, first let's take a look at global warming, which is a shorthand for global climate change. The predicted rise in temperature by 2100, which is around 2 to 3.5 degrees, will cause a number of problems which will impact seriously on health. Disruption of agriculture through changing rain patterns and soil use will obviously have a major implication for those that already don't get enough to eat, and starvation is a major anxiety. The rising sea levels will displace many people by 2100. The extent to which the sea level rise is going to be, of course, much debated. But most of the great metropolises of the world are close to the sea, and significant sea level rise will displace many more, in fact, than 120 million people. That's the minimal that we consider may be displaced by this particular problem. There are, of course, climatic conditions which favour things like mosquitoes and other beasts and insects which transmit disease, and the likelihood is that their area of activity will extend significantly, and the prediction is that, for instance, there may be another 60 million extra malaria cases a year. And then, of course, there's a problem of extreme weather, heat waves, hurricanes, flooding, and we all know even now of the damage this causes to people's livelihoods and therefore their health. But most important is they're very well known and in some respects simple to outline in a clear way. What we need if we want a health-creating civilization, which of course is the objective and aim, I think, of all of us who are interested in global health and health for people at large, is first that all people have reasonable access to economic and social resources. There are many of these, and we may come back later to defining that more clearly, but in essence a good marker is that money, which is a reasonable marker of the composite of economic and social resource, is reasonably clearly and equally distributed through the society. The second is that Earth's gifts are shared amongst humans fairly without compromising future generations and other than humans. This, of course, implies that we live within our environmental limits. So, what we need for a health-creating civilization is that the social, environmental and economic determinants of health, which are, as I've said, that we have a fair share of resources and we live within environmental limits, are woven into a tapestry supporting a fair shares and so healthy world. I don't need to tell you that that's not the present case, and there are two great problems which are undermining this wonderful concept we have, this wonderful idea which needs to be turned into a reality of a health-creating civilization. They are global climate change and the everywhere prevalent gap
in /room space R1. You can ask a question or make a comment at any time during the presentation. If you're responding to someone else's comment, please remember to preface it so that others know who it is aimed at or who you're replying to. So, for example, type in, "Paul, can you tell me?" or "Janet, I disagree with what you say." I'd now like to introduce to you Dr. Robin Stott. Robin is a former consultant general physician and hospital medical director who is currently chairman of the UK Medical Peace and Environment Group and co-chair of the Climate and Health Council. Robin will talk about some of the consequences of global warming and their impact on health. Welcome, Robin.
Thank you very much, Janet. It's great to be here. Over the next 15 minutes or so, I'm going to, predominantly from a health perspective, talk about some of the problems which are going to confront us in this new era of climate change. The talk outline is as depicted here, and I'll go through each of these in turn. But first, why is climate change such a problem for health? To answer that question, I really need to talk about what actually constitutes good health and structures and frameworks which will facilitate the emergence of good health in our societies, and that this will actually cause enormous social and economic dislocation. And we know from the unfortunate history of the last 50, 60 and 100 years that this gives rise to substantial health problems with a major increase in death, particularly of women and children. And of course the other thing which is really important to recognise is that the global warming and climate change, the impact of this, although it's going to be on all of us, is going to be greatest on the income-poor world, and so it will increase the resource gap to which I alluded earlier on. And just to highlight what that resource gap is, it's worth looking at one or two figures. 11 people own more than the total GDP of the 49 least developed countries. If you look at global trade, $10 million a minute, the 49 poorest countries have 0.4% of it. If you look at high-income countries, 20% of the world's population consume 86% of the goods. 40% of the world's population in 64 countries have an income of less than $2 per day. And 2.4 billion people lack access to sanitation, and 1.1 billion have no water in their homes. Infant mortality rate, which is what IMR means, is a measure of deaths per 1,000 live births. In Angola it's 250, in UK it's 7. Life expectancy, Angola 40, UK 78. Maternal mortality per 100,000 births, Angola 600, UK 7. I think we need say no more about how disparity has such a terrifying impact on health.
Good afternoon, my name is Janet Richardson and I'd like to welcome you to the Faculty of Health and Social Work webcast on health, climate change and oil vulnerability. We have some excellent speakers here today. Each will give a presentation and you will be able to ask questions following the on-screen instructions. For typing your comments, use the box at the bottom.
Oops.
If you have any difficulties, please contact Sito Maramba and the details given on the slide. You can either email him or call him on the number. The four speakers are Robin Stott, Linley Owen, Andy Nichols and Rob Hopkins, and each will have a chat room of their own. You are currently logged on to the main chat room, and each speaker has a chat room. The next slide will give you details of which chat room to log into for each of the speakers. To change from one chat room to the next, simply type in the number of the chat room and that will log you on.
So I need to try